So Chandresh will come and give the presentation, as I said, of the landscape right now.
All the ideation, all that will be very good if other people join. This participation, I'm quite disappointed because there's some groups who started working on their own. They talked to me, we are doing something. I said, "Wait, please, let us be going together." So I don't know why other people are not here who have started their own thing, because then what happened? We all would have been doing it together. And also, what we are doing is we will bring up point problems. That should not be done at this forum. This forum is more for the roadmap for a longer term, which we have never done in Auroville for health sector. We started with prosperity, we started with health sector, and later all of you, all those who are here, supposed to take up into various groups, and there also people should have signed up saying, okay, I'm here, I'm interested in all that. I wish that when we send to 30, 40 entities, I wish that 81% from if you that year, we would have had this. Otherwise, it's we do this kind of meeting in Auroville and it's meaningless. But anyway, I don't want to gripe at all because as FAMC, we trying to put forward a roadmap that will help what we see, and then we take back from there on the budgeting side and what we can do. Okay, but this you will have to redo with everybody again, please. You will have to redo this again. So it's meaningless. This meeting has little value if we don't get everybody in the health sector together, right? Those who are at least working together, they should be here. That's my, to all of you who are in that sector, please inform, tell. I don't have to be at that point. All of you be there, work it out along the thing that we all done, right? Now, I just wanted to share from FMC perspective the lay of the land. 3.5 years, we also have been working with Health Fund. I wish Health Fund was here. You all had a meeting yesterday. Why are they not here? Because Health Fund is the one major area that talks to all the residents, right? So they have information that would be helpful to the rest of the people. And also, what are the deficiencies? What I will cover here are only generalities, but each group has certain deficiencies they know. The challenges they know. Okay. Duplicacy, they know. So I'm providing an overview of what we have found out with BCs and FMC over the last 2-3 years. But apart from this is where everyone take this information and start working within each group, but come together with this next level. We have to restructure our health fund, health services as Auroville, as a wellness partnership, and FAMC can't do this, which is the prosperity. Community has to do that. In this case, the health sector communities have to do it. Okay, I'm just giving you feedback, and then you all as a group decide how to bring it together. All right. So what we are doing is, just one moment. With BCC and FAMC, we have looked at, these are our reviews. Some areas people may agree, may not agree, but this is what we have seen and put together, and then we can always refine it if we need to do a little bit. But this is more for understanding. Okay. So this is our today's present structure. We have multiple independent health units. We have separate administration accounting in each of them. Then we have a recurring budget and maintenance support for all of them. And there is additional patient income and donation that are needed because our centralized budget is very limited. That's the current reality, right? This is what it is. I will share this actually. Oh. Yeah, I will share this also recorded so that everybody is in the same page. Those who couldn't come, I wish that they would look at it. So we can have a follow-on meeting next week or 2 weeks from there. They can all meet. Whoever is working together, please let's get them all together. Okay, next. So these are just numbers that will give you an idea of where we are. But what we have to do, where the lacks are, that will be the second part of administrative, how we can work together. So currently, the maintenance, Auroville maintenance is 92 lakhs per annum.
But the general maintenance, general maintenance.
No, the maintenance for the people in the health sector.
Okay.
The units that are in the health sector.
Okay.
Those are under health and healing who are registered as a city services.
Okay.
City service,
Okay.
under city service.
Yeah, that's it.
Yeah.
So it's a city services maintenance given to Auroville.
Medical center.
Yeah.
The health sector.
Health
Yeah, health and healing under health and healing. The big one, health fund, Sante or whatever, Mahalakshmi, all those.
Dog shelter.
No.
It is under health.
Right.
Okay.
A good one. No, sorry.
We are receiving a budget of two.
Okay, so recurring budget for the sector is 247 lakhs. Okay. And then there are additional budgets and donations that each of the units do expense and raise or bill. And then the patient revenue also from services. Some of the entities also have an additional patient revenue. Even each time everybody walks in, they have to give additionally this amount, whether they, whatever service they take. Okay, next. So first category is of course from the BCC community support, and recurring budget goes for the operations. Now additional support budgets and all that is what they are spending. The special support is a category that supposing somebody had a tooth thing which was additionally from whatever, then that gets reimbursed. Or if they have eye surgery for the, so that gets reimbursed. So all those are the special support, and this is just a representative of last year, right? So that is 39 crores, 39 lakhs, and then grand total is this is what BCC spent, okay, 3.4. Now, what happens is this is what BCC spent, but there is also what we collect, right? The health fund, we collect 660 per month. So actually, I've asked them to give me the information. If you can ask Kalai to give me how many people are in that health maintenance and how much per month and annual we collect. So that supplements.
2,000 people now in the health.
You'll get the number. It's better to have the number. So that comes and gives to the health fund accounting. Okay, next one. We have total income from everybody who is served 741 lakhs, and we are spending currently 747 lakhs. 5 lakhs of difference. We're not going to go into where it is. Next. And yeah, as we said, 5 lakhs of deficiency in our operation. But the other thing that was brought out was income and expense after depreciation. What happens is we are building the equipment, all that. So in the books, they will be put. But we don't budget for it, a depreciation. Neither we put it aside or expense it out. Now, it's just a book accounting thing, but some down the road, this will get old and replacement and all that. So we are not planned for anything like that as a sector. So our planning and budgeting, we need somebody little more knowledgeable about planning and centralized budgeting for the health sector as a whole. Like Sire should do for a lot of areas. In fact, we need specialists to help us structure frameworks for that. For each of the major sub accounting heads. So this will need that. Put a position for that. Because we need to actually understand how to maintain our long-term viability and what are the costs for it, total real cost. Of course, there will be deficiency. But we need to understand those deficiencies so that we can approach GD or other sources to say how to balance the gap.
It's part of the roles and responsibilities. Can you
Yes.
go back 2 slides?
Yeah.
I want to clarity a little bit so that you said total spending is 3.4 crores.
Yes.
And the next slide, can you, for everyone's benefit, can you explain how the 3.4 became 7.4 expense?
Because they get it from people charging. So it's like, in our prosperity, you have the fixed cost, which is the health maintenance and BCC, all that.
Plus health.
But they independently, whenever they go separately, they get, or some people have their money, seniors, they give that. So this is just again breakup of what the things are and it adds up to that. Okay, fine. Next. These are the general expense clarity that everybody has. All the departments that are funded, they all have these expenses. Okay, that's why your centralized, coordination makes more sense. Not everybody has to know it. Okay, so those are all the various. This is just a understanding of where BCC looks at all this for all the departments, and they all submit their balance sheets, and all that gets consolidated, which is replicated 8 times. Okay, next. Key problems side, fragmented governance, because as you all see, one person doesn't know what others do. We have no understanding of general health, or what health we are covering, what is excluded, and what are the key problems that people are finding in Auroville today to get their health covered. All those things are fragmented governance of the health sector, lack of centralized financial control. Again, Similar, when we need to have a really centralized budgeting and planning. We may not have the money, that's a secondary, but first we need to know what we need. Now we at least know that we are spending 7 crores.
Right.
And if you know where it is going, what is getting who, and then we can review it, and also maybe other ways to work on those.
Yeah.
And then duplication of administrative expenses, and basically weak transparency, accountability of expenses. This is what has been observed in BCC, looking at the balance sheets and all that. Okay, we're not going to say 1Z, 2Z, what is what.
One more problem. Yeah.
We can add, this is what we have put, but you can add. Sure.
Lack of utilization.
It's replicated. That's
Yeah,
That's a
duplication.
third
That's a-
duplication.
Duplication.
yeah. I mean, instead of expenses, you can say personal.
Hmm.
Personal.
But actually, I'm looking for one resource. That is all.
Okay.
Yeah.
So we can
Lot
say
of duplicate.
not human resource, not optimally deployed. Okay, we can add that as part of the WC, this, yeah, wellness coordination group. Okay, next. Again, this is operational complication for the health sector as a whole. Each unit functioning independently. And as a group, they should every 2 weeks or 1 month have some overarching thing that they work together on. No integrated patient records. Again, AIS needs to be updated with all that, right? No centralized procurement of anything that we need.
Yeah.
And also deployment of, people go to this, oxygen and all that. So that will have to be reviewed as an operational thing. And then variable patient charging system, that is there today. Okay. But I don't know how to address it. We'll have to see separately down the road. These are observations we have
So this
seen.
is a complication. So
Huh?
this
Huh.
is a complication. Right?
Correct. That's what. So we have to see how to work with it. Okay, next. So these are the governance and compliance risks. Again, this was done by BCC. I'd given all information. Some things are from Andhra. He's not well this week. Not well. Otherwise, he would have.
He was working on the wellness trip.
He's senior, no. Possible gaps in clinical compliance again. Possible gaps because BCC doesn't know it, right? So this you will have to address it. Like we know that many people are signing up as therapists, but there are but few previous FAMC we had said, look, there has to be a code of conduct for therapists to practice because there were complaints again, and where, location, all that. So compliance in many areas, we don't. I mean, FAMC can't recommend anything, but that maybe will have to look up one of the.
In what we
And as I also said about the accounting wise, we are doing the entering in the books our depreciation, but there is no oversight of how we are going to work with it and all that. Right?
Yeah.
So the whole issue of centralized budgeting and plan. And then potential medical legal vulnerabilities again. These are put
Yes.
for observation and people can look into it because we do not know, but these are potential things. Today we don't have any information whether we are compliant with it.
Correct.
Okay, next. What we are trying to say is let's move towards how to do it so the collective benefits can happen. Universal access to healthcare support. If you are centralized, we know what is there weekly, update the data record. If there was somebody going to hospital, the data is available, if something else, whatever, right? So, and then affordable medical access. This is an area that we're trying to see with senior. If Ayushman Bharat can be used for seniors, let's see what is required. And also, I'm gonna try and look at group insurance because what happens is there are many things that our system says no, not approved. It's not in our policy, and that cannot happen, right? So, I'm gonna because now we have all the numbers.
Who said it cannot happen?
earlier.
Earlier.
Not happen means somebody is the thing happened. No, accident happened. We'll only give it 2.5 lakhs.
Or like
It's not question not happening. So what I'm gonna do is I'm gonna start as FAMC at this data. Look at group insurance policies, but we will need to have from there what are the they'll offer you 80% of possibilities and all that, right? So there we'll only have general health, vision, and dental, all of them. Look at the policy, people can help in assessment, and then I need this. I've already asked somebody, but I need this very critically. I need the demographics. age demographics is very important. On that, the quotation can come from insurance companies. Mental health services. Now we have mental health, which is, we have doctors in it, but we don't have experts in the mental health. So there are many patients who've had and over recurring and all that. So it's a big ticket item that BCC covers. And so we'll have to see. It's a gap we don't know how to cover. And then also outreach services we have in Kulipalam area. I don't know the effectiveness of it. Can be reviewed.
Correct.
We feel that it is over, huge facilities.
Yeah.
Underutilized, and then covering now, because today any service
Of government is
outside is
yeah.
far better than what they offer there. So these are some of the things we have identified.
Yeah.
Collective
These are
benefits
legacy
that can
systems
be,
which needs
we
review.
need review. Okay, mental health outreach services need review, and of course the pharmacy needs to be shifted in the center. There is also already
And also
find
pharmacy,
there's
that's
100
it, right?
meter. There is another pharmacy we need here. Okay, now, so this one is okay, as you all talked about it before, collective oriented healthcare philosophy, and that is what outreach, education, food, yeah, sick, and also lifestyle choices, all that stuff. Fine, next. So this one again, collective satisfaction and challenges that we have experienced based on whatever we get requested. Can you submit this? This is from DCs and FANC. Inconsistent patient experience. Different people get different things. Lack of specialist availability on site. Every time we just keep running off, sending off. Increase a lot of our budgets. Budget conflicts among units. That I'm not sure Honorable may have a
In
better
fact, that you
understanding.
should say what you said before, that the taxi bills are one of the biggest bills.
Huh?
The taxi bills are the big bills. We settle
Not
for
taxable
going
per
to
se.
different
No.
hospitals.
That is, of course, that if somebody goes to Apollo, even our group health insurance will not cover. They also will have a recommended hospitals and outlets and all that, but they will have much better breadth. Okay. So this is coming from BCC because they work on it day to day, every week, right? So this is coming from there. Their observations.
Yeah, what do you mean by that? What are a few things you can get?
BCC is not, I don't want to interpret them, but they are saying that the budget conflicts among units, we have to ask them, and then unclear unit structure, who has to do what? Possibly. Because there is, he is not well.
Because of reward sector.
He's not well. Yeah. No, like I think Sante gives some services, but they are not doctors, not there. Arka also gives services, So existing funds support stronger integration of the unit, reduce duplication. But services can be centralized, whatever, decide how. Potential for permanent doctors, we need that, it's required. Structured insurance system, we will look into that. Centralized governance, we are suggesting that. Next. Recommended new structure, this is recommendation, okay. You folks will have to do it. Create on Auroville integrated health, community health system, that's basically the digital infrastructure. Merge all administration, one framework, that we all do. Central administration financing will do that. And then unified healthcare delivery model that based on what health insurance give, what other you do like palliative, whatever else you do internally. So unified. Next. These are suggested, recommended, right? So 4 major functional wing. That's what we
Yes,
see.
we have-
But again,
yeah.
you will have to take up primary care wing, specialized care wing, emergency insurance wing, and administration finance wing. That's where all the digital infrastructure, all that will come together. Yeah. So this is a suggested restructuring of the whole health sector as a whole, but you all have to do it together. Next. Unified budget approval, that again we said they will go from there. Next. This is suggested. Next is general 6 months. If we can come up with a budget. Again, suggested. Let's see how it goes. Next. Phase 2, central health
Go back a
campus.
little, what do you mean by centralized accounting? You already have Zoho, what else do you mean?
Probably centralized, digitalized data.
It's available on. No, I mean basically when you go there, then we central. See, today it is but there's no
Well, even
what they're expensing out, there is no oversight. It just some.
taxes and all this.
It already
It's
is done, I
bookkeeping.
got
It's not centralized accounting, it's central bookkeeping.
Ah.
Okay, that's the difference. Okay, fine, next. central health campus, permanent doctors recruitment, digital medical record structure referral system. So that last one is interesting. Okay, next 6 to 18 months structural integration. Then phase 3 insurance and sustainability, collective health being wellness, collective health well-being scheme, tiered subsidy model. I don't know what that is, but that is his data. Emergency reserve fund, it's a good idea. Volunteer and visitor policy, which is we don't know if habit or not, whatever. Have to take it. Preventive healthcare focus, you already talked about it. Telemedicine partnership. Next level, annual community satisfaction survey. Surveys we had talked last year also. That surveys would help us get better aligned. Model community healthcare. This is our vision. Okay, that's your vision also. No? Next. So this is the conclusion. This current system is compassionate but fragmented. Need integration plus transparency, professionalism, financial sustainability is achievable. Means it's not there today. It's not there today. We all know. Potential to become a model healthcare ecosystem. Our wish. Next.